I'm going to talk to you about hormonal factors in migraine. I'm going to be cheeky though and just talk about the female gender issues. So whilst I'm co-secretary for the Australia and New Zealand Headache Society, I'm not representing their views tonight, and I have been on advisory boards and done educational activities for 4 of the companies most interested in migraine. So why do hormones matter? Well, clearly there's a difference that at menarche, women have many more migraines than the male population. So the red curve here is females and the blue curve there is males, where there is a slight increase, and in fact if you look at 1 year prevalence there's a little bit of a blip for both of them at the beginning and at the end, but really overwhelmingly it seems to be the female hormones driving this. So menstrually related migraine is the most common that we see, and so this means that it will occur before and during the first days of the period on more than 2 of 3 cycles. So it doesn't have to occur with every period, but it has to be more than a chance finding. So a lot of women come in convinced that they've got a hormonal trigger, but if it's happening just as much all the other days of the month, there may not be much success in managing the hormones. The reason it matters is menstrually related migraine attacks are more frequent, they're longer lasting, they're more severe, they're more likely to relapse, and they're much harder to treat. So in other words, in case you haven't figured it out, menstrually related migraines are worse in every single way. So they are often, when we're teasing out migraines and headaches, people often don't even tell me about their lowest grade headaches, and they tell me about their showstopper migraines, and in women that's often menstrually related. So we need to understand more about the treatment of these sorts of headaches. Pure menstrual migraine is really rare. It's less than 10%, I think it's less than 1%. I've never seen anyone who's only ever had migraines during that high risk time of the early stage of the menstrual period. So by definition they're not allowed to have any migraines on other days of the month, and I think this has been mainly made up for research purposes, but these are rare beasts. So how to identify menstrual migraine? Well, the most important is a diary. So it's not just for the doctor's conviction, it's also for your own personal knowledge as to what's relevant and not relevant. So when we ask people, not through any will, the under and over reporting is really significant. So you really need a diary. If I was going to tell someone about my headaches, I'd need to have a diary too. And also when you've done a diary, assessing the response to treatment is also helped. So you can see it going from really messy, say, over here to much better, where you've got many more headache-free days. And hopefully that's not just because they forgot to fill out their diary. Hopefully it's something I did. So the things to note in menstrually related migraine is how predictable and reliable and regular the periods are. If they're all over the place, you can't predict when that estrogen drop is going to occur, and you can't preemptively or effectively treat it. It's really important to ask about associated symptoms, whether they get any of that perimenstrual symptoms of bloating or period pain. And it's not so much that you're asking about how bad their pain is. If they've got any of those uterine symptoms, there's other factors such as prostaglandins at play. And if they've got heavy bleeding, then you can have a relative iron deficiency later on in the period cycle. Whether they have aura or not, so these are usually visual, but they can be sensory or motor symptoms that gradually progress, usually over 20 minutes, but they can be 10 minutes, they can be 2 hours, and they usually herald or start before a migraine headache starts. So aura we're going to talk about a little bit more. And also it's really obviously important to see what happened in other hormonal states, like high states like IVF, use of contraceptives and pregnancy. So this is the most commonly used diagram of what's happening in the stage from producing the follicle, ovulating, and then having the period starting there. So we've got a couple of important blips, and that's mainly the estrogen. So this is a very one-way, unidirectional philosophy we've got, and I think there's probably much more complex interplays, because sometimes we do something that shouldn't change estrogen, for instance, and it still has a hormonal impact on the amount of periods, menstrually related migraines they have. But in the most common case of menstrually related migraine, it's when the estrogen drops, the big green arrow, that causes it in the 2 days before the period starts and then the 3 days after, because you can see it's continuing to drop. And then there's also, so that's where the estrogen's dropping and where the headache starts. And so it's usually 2 days before and the first 3 days of bleeding. So independent of estrogen, like I said, prostaglandins may have a role as well on sensitising the head. And then the heavy bleeders can have a relative iron deficiency. So I thought we'd walk through, because it's quite complex, I thought we'd walk through what I think are the stepwise main considerations in managing this. I think it's good to recognise it's the most important subgroup because it's so severe, but really what everyone in the room wants to know is what can you do about it. If the periods are really reliable and it's really related to the period, you can use your treatments in a way that we call mini prophylaxis. So you can start your most effective treatment like naratriptan, which is a really long-acting triptan, or naproxen, which is a long-acting anti-inflammatory, that have both been studied in this condition. And you can start it the day before you reliably wake up with an established untreatable menstrual migraine and continue it twice a day, or in the case of naproxen, it's once a day, for the duration of that high-risk time. And as you can tell, that means that some people will be using 5 to 7 days of the naratriptan, which when you're wanting to avoid medication overuse gets a bit tricky if they've got 10 days of migraines the rest of the month too. So this is for a very specific subgroup. Some of them do get a headache also on the day after stopping it, so it's a bit tricky, but it's helpful in some people. And we'll go through a case study so you understand that a bit better. The second, and probably the most useful thing to do, is if they don't have any contraindication, you can use a continuous low-dose estrogen combined pill to suppress ovarian function and the estrogen changes to stabilise those hormonal fluctuations. So you basically are allowed to choose the timing of when you stop it to have your sugar pill to avoid other triggers and to avoid important times in your life like your wedding day or your end of financial year at work. And you're allowed to then also gradually skip the sugar pill on subsequent cycles until you're having less periods without breakthrough bleeding every year. So you can get down to 2 to 4 withdrawal periods a year instead of 12 by knowing how many of these sugar pill parts of the cycle you can skip without it naturally wanting to give you a period. And you can also put an estrogen patch on, but the overlap gets very tricky. So women need to have some menstruation during their reproductive years, but you don't have to have 12. And similarly, even just shortening how long you take the sugar pill for. So a 7-day sugar pill duration was designed by scientific men. We don't need that. You can have 4 or 5 days as long as you've had enough menstrual bleeding and then reduce those high-risk weeks. But the reason we ask about aura is that there is an increased rate of risk of stroke when you have aura if you're given artificial estrogens. So it's in the order of 3-fold of the natural history of migraine with aura, and that's sort of the opposite of what we go to work to do each day. So my aim in life is not to triple the risk of young women for stroke, it's sort of to do the opposite. So it is still a very small risk, it's a tripling of a tiny risk, but it is still an increased risk to the point that most guidelines are not backing us up in giving the combined pill to anyone with aura. So it's important to make sure you're clear that you have aura. Some people get a bit of blurred vision before they feel a bit faint at the peak of the pain. That's not aura. So some aura is naughty and it happens in the middle of the headache, but aura is a really distinct neurological stereotypic event that happens usually before the headache. Some people also find that estrogen, such as in pregnancy, worsens their headache even if it helps it for most people. So life is sort of designed to be unfair and you have to figure out what's best individually. So the latest guideline was the European one, which supported previous World Health one saying that all women with migraine with aura should be on only permanent methods or progestogen containing contraceptives rather than using estrogen supplements. And they suggest actively seeking out these patients and switching to non-hormonal contraception. Whereas in migraine without aura, if there's no additional risk factors, they can take whatever they like. The third thing you can do is perhaps use progestogens, even though they don't fit neatly into our picture of how they cause or change estrogen drops or headaches. There's certainly some suggestion from pooled analysis of 4 studies suggesting that we should at least study this more. So I think anything you do to decrease the highs and lows of hormones seems to help migraine a bit. But more often people come in saying, I have worse migraines during my periods, we should therefore fix my periods. But more often we're actually fixing the whole person the whole month because really they have enough headaches that hormones are not the only cause. Just like usually it's not just that the neck is the only cause or caffeine is the only cause. You know, it's very rare for there to be one triggering factor. So the progestogen only pill reduced the number of migraine days, the intensity and duration, and also the amount of painkillers or triptans that the people needed. So that sounds very promising. The fourth thing, like I said, is if there's any of these perimenstrual symptoms like bloating or cramps, then using something targeting the prostaglandins like naproxen can be quite effective in helping the triptan to work better. Now, the fifth thing, this is what everyone begs for, just take it out. Why don't we just ablate the estrogen fluctuations with a hysterectomy? Well, hysterectomy with or without oophorectomy, that's taking your ovaries as well, actually increases the risk of migraine. So I've got a nice little cohort who are unfortunately worse by trying to solve their menstrual problems. So we don't recommend hysterectomy unless it's needed for other gynecological reasons. Rarely, and this is where it gets really complicated, we do a medically induced menopause, and this is under the care of a very subspecialist gynecologist, because you've got to consider bone density, vascular risk, all sorts of factors. You know, one of our advantages in life is that we have estrogens, and it's a pretty rough, rocky road initially if you're medically ablating it quickly. Okay, so to do a case study, we've got a 39-year-old lady. Her migraine started in high school, which is that typical age when the peak takes off, and she's had progressively severe migraines, particularly around her period. She has blurred vision with dizziness at the peak of the pain, but she doesn't have loss of vision, sparkling lights, or any distinct positive or negative visual symptoms. She's sleeping well, she doesn't have jaw or neck pain, no caffeine, so she doesn't have caffeine withdrawal. She has a normal full diet without deficiencies, and she has regular normal periods without any suggestion of premenstrual symptoms. She's otherwise well and doesn't take any regular medications, and she's quite busy working in 2 high-level roles. And this is what her headache diary looks like. So on these headache diaries, and I'd like to acknowledge Paul Spira who designed these, we underline the days of the menstrual period and we circle the days of any significant headaches. And so her headache typically starts the day before, or in this case 2 days before, which is spot on for what you'd recognise as menstrually related migraine. This cycle, it also started the day before. Now for her, for some reason, it goes on extraordinarily long. I was wondering whether her neck's locked up by this stage, but you know, I don't quite know why hers went quite so long, because usually that'd be more a classic pattern. So she'd tried preventers, including topiramate, amitriptyline, and sodium valproate, and she had side effects as well as a lack of effectiveness in decreasing her headaches. She found them too difficult to treat with lost time from work and other activities, despite trying all 5 of our available triptans, as well as trying the naratriptan morning and night. So she started the low-dose continuous oral contraceptive pill. And within 3 months, she was 90% better, with 3 easier to treat migraine days each month that she could actually get on top of. And over 2 years, she was able to reduce the frequency of her menstrual cycles to 3 times per year. So she can now choose the timing to avoid her intercurrent busy times at work. She can predict when the headache's starting with the sugar pill, and she can also reduce the number of menstrual exacerbations she has to have each year. So in her case, it was really important to make sure I was satisfied she didn't have aura and I wasn't tripling her risk of stroke. And so we don't shy away from a little bit of blurred vision at the peak of the headache because that wasn't specific enough for an aura. Menstrual migraines are the hardest to manage for sufferers as well as for clinicians, and so both need a really good diary to understand how relevant it is and how much of the focus should be put on the hormones. It's usually mainly the ongoing small estrogen drops that we target, but prostaglandins might further sensitise the head, so we also target them. But use of estrogen is not a simple matter and not always successful. We particularly avoid it in migraine with aura due to the risk of stroke, so it really requires careful consideration, usually with a headache specialist or a gynaecologist with an interest in this area. Okay, so that was menstrual migraine. Then migraine in pregnancy. Most people, I usually quote about 70% because it seems to be a little bit halfway through there. Most people improve, but unfortunately it's by the second and third trimesters, so it's ignoring the first 12 weeks. The improvement is more likely in migraine without aura, because the aura ones are the ones that kick up, but I haven't found that it's neatly in that group. It's usually in those with menstrual migraine and migraine that began at the onset of their periods. But there's another group that you've promised 70% improve that get worse, and so some people can be worse during pregnancy. It's really important because pregnancy is such an abnormal high hormone state that we exclude underlying causes if the headache suddenly shifts into a more sinister headache, to make sure there's none of these high pressure states like clotting and those sorts of things that we talked about out of the setting of pregnancy. So sometimes we need to do an MRI in the setting of pregnancy if it's behaving bizarrely. The problem with treatment during pregnancy, and so this is taken from the updated Australian therapeutic guidelines, which really means that every doctor who can access this can get details of what medications are allowed, what doses are suggested, and what to move on to next if it doesn't work. So they're a really good resource for doctors. But really, we're not allowed to take many medications during pregnancy. So suddenly having days off work, resting, using a cool pack, crying under a pillow, using an anti-nausea tablet is now allowed, wasn't back when I was pregnant. And first line treatment is paracetamol with what we think is the safest profile. Codeine can be used if needed, which is very different to our usual outlook on migraine because we're usually trying to get everyone off codeine. But really, if you need something, then we've got longer term experience about the safety, but we still have to try and avoid medication overuse. And then third line, the triptan with the most experience over the last 30 years would be sumatriptan. So some people that have a triptan that might be more effective for them specifically would probably still be referred to going back to the first triptan that we had many decades ago, sumatriptan. And so this is just based on expert opinion rather than in any clear trials. Ethics won't let us experiment on pregnant women for very good reasons. But I think it's a move forward that at least we can try some things. Again, the anti-inflammatories that a lot of people rely on, like aspirin, Nurofen, Voltaren, indomethacin, you're only allowed after the first trimester because it's a disaster if you take it when the neural tube's forming, and also before 30 weeks because it's also a disaster if that changes how everything closes in the heart and also bleeding and delivery. If things are really dire, the person's admitted for hydration, magnesium is felt to be safe, and even a short burst of prednisolone. So it's a tricky case, but luckily 70% of people are better in pregnancy and we won't worry about any of that. If they're needing prophylaxis, so their headache's too frequent and severe and we want to reduce that, then propranolol is the one with the first line safety and amitriptyline is second line, and I usually refer to the latest review articles by experts and guidelines as to what to tell the patient about the known safety. So for instance, you might be talking about medication that causes problems in rats at high doses but not known to cause problems in humans at low doses. So that's still very important for the person to have informed consent that they're happy to take that rather than suffering with the headaches for that definable illness that we call pregnancy. I wasn't good in pregnancy. I think pregnancy is a terrible disease. But anyway, so perimenopause. It would be really nice if there was a moment at menarche, 12 and a half or 15, depending on their maturity, that these headaches kicked up, and it'd be really nice if there was a blip for a month or something when menopause set in. But unfortunately, there's this big jagged line of looking terrible and getting a bit better, looking terrible, and everyone points a finger and saying, what are you doing wrong in the adolescent years? And there's a similarly chaotic fluctuation of hormones for many years around the menopause. So this state can go on for 5 years, and menopause is just a neat medical definition that it's 12 months after you had your last period, even if you'd been having them every 6 months before that. So it's a little bit of a chaotic period. So irregular periods suddenly make this predictable treatment with many prophylaxis difficult. There's an increased risk of migraine during these years, usually 5, but it can be 10 years. And if life is fair, it gets better after the menopause, so everyone's just holding on to that hope. And then the other things are, if there's major sleep disruption from sweats and feeling horrible, then it's really important to use an antidepressant with sedative side effects like amitriptyline to have a good solid sleep. Not to forget the things that aren't heavily marketed, like evening primrose oil. And other people use the serotonergic antidepressants a bit more. And gabapentin is what the Europeans use to reduce this flushing and those symptoms. So sometimes you can kill 2 birds with 1 stone. Hormone replacement therapy can be considered whether you do or don't have aura, which is really interesting to me, because hormone replacement therapy, if it's the medically designed ones, have as physiological as possible dosing of estrogen rather than being super therapeutic like the contraceptive pills. So we usually use it more for gynecological reasons, and it has to be carefully balanced about personal and family history of breast and ovarian cancers and those sorts of things. But it is possible to use that if it's too much of a roller coaster. So migraine as a whole is an important debilitating disorder, and I'm not treading down on the males in the room and how significant the migraines are. But menstrual and perimenopausal migraine are often more severe and challenging to treat. I think every talk on this that I give is that further research must advance our ability to do good whilst doing no harm, such as minimising the risk of stroke, but also even normal migraine treatments should be tested with rigour as to whether or not they also help the menstrually related subgroup that are so severe. So yeah, it's a really important area, and I was pleased that the feedback from last year is that this is an area that Australian people are interested in.